To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you. To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are placed through the trocars into the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. In preparation for the band, a tunnel is created behind the stomach. The realize band is introduced to the abdomen through a trocar. The realize band is positioned around the upper portion of the stomach and then secured using the locking mechanism. A tube attached to the realize band will be connected to the injection port. The port is used to adjust the band tightness after surgery. An incision is made on the upper abdomen to insert the realize injection port beneath the skin. The tube is secured using the locking connector on the port. The injection port and tube are placed beneath the skin. The realize band does not alter your digestive function. Food consumed passes through the digestive tract in the normal route. Your surgeon may tighten the realize band by injecting saline into the injection port. As the saline is introduced to the realize injection port, it travels through the tube to the band. The addition of saline to the band creates a smaller upper stomach pouch. This smaller stomach pouch restricts the amount of food you can eat before feeling full. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you. The sleeve gastrectomy is a restrictive procedure, which limits the amount of food you can eat by reducing the size of your stomach. To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form, so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you. Digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy. As with all...
So, any questions about these three procedures? I can move on to the next part. Okay. Because to go over the complications and stuff, I'll be more than happy to do so. I'm not sure how many of you would be interested. So I'm going to summarize. So in conclusion, I think the big thing was is that to make awareness of the degree of problem that or a burden that obesity is right now to ourselves, as well as to the healthcare community, and it is a well-defined disease that causes, as we all know, so many other medical comorbidities and the metabolic syndrome. And the patient with obesity should be recognized as deserving treatment for this disease. The simplest and safest treatments should be used first. So if you find out if your patient can achieve the weight loss without surgery, I think that's the way to go. But if that person has not been able to achieve that result, we need to do something about it. And we have good evidence to highlight what that something is. For patients who do not achieve substantial and durable weight and comorbidity improvement with non-surgical methods, bariatric surgery should be an available option for the suitable individuals. And in terms of the surgery itself, the gastric band, sleeve gastrectomy, and the gastric bypass have been proven by a lot of randomized controlled trials to be safe and effective. I would like to just share a few more thoughts about the relationship that you and the center. I would like to start that relationship. I think we've already started that relationship with some of the doctors there, but today was a way for me to reach out to the medical community in the area that I'm here for just one goal, which really is the treatment of obesity. And our patients, our mutual patients should benefit from that. And anything that I or the center can do to help make that process easy for you, I would be more than happy to do that. In other words, if you need handouts that will make it easier for you to do the counseling part in your office. A lot of the practices are very busy. Counseling for obesity takes a lot of time. And there are ways that I can help you with that. And one thing I also wanted to say that the patient is yours and will always remain your patient. I'm a specialist. Treat me as an obesity specialist center, because I've heard these in the past 6 months. These are the concerns that I've heard, and I wanted to address them. With me introducing a medical doctor in the field, in my group, just basically means that I recognized how important it is for medicine and surgery to come together for the treatment of obesity. I have no desire to take over the primary care role. I cannot take over the primary care role. And really just look at this program as an obesity specialist center. And you will be kept updated with the progress from the time that I first see the patient in the office till after surgery. Another way that we can help is to document the weight. When you see the patient in the office, for whatever reason, please encourage your staff to document the weight. Because when they come to me or they come to any other bariatric surgical program, one of the big challenges that we have is providing documentation of weights. Insurance companies require 6 months of weight documentation over the past 12 months preceding to surgery. This is how strict the criteria is. And I can't go back in time and make up numbers. I guess I could, but that's not the right thing to do. So I'm relying on, when the patient comes to me, to have the weight documentation from the doctor's office. So just if you can inculcate that, just the way they measure, the staff measures their pulse rate or their blood pressure, just have them measure the weight. And even if your scale does not go as high, like I had a patient, a BMI of 72 the other day, her weight was in the 400 pounds, and it doesn't matter, just write 300 plus. At least we documented the weight on that event, and that information is very vital for me to get the case together to go to insurance companies. The letter of medical necessity for bariatric surgery. This is something, again, the insurance companies require me to provide. So a few of the physicians here who have referred patients to me, I don't want to increase your workload, but this is a criteria that I did not make. I wish it was in my hands and I would chuck that out. I have a medical doctor, but they still require the letter of medical necessity from their primary care physician. And obviously the preoperative test and the postoperative follow-up. Some of the postoperative consideration is size of the pills. I tell my patients that after surgery, you will have to crush most of your pills. How to manage the blood sugars, the glycemic control, and the role of vitamins, and the rate of weight loss. So if you see a patient in your office and who's not losing 1 to 2 pounds a week, please pick up the phone and call me. Our goal in the first year is they should be losing 1 to 2 pounds every week. And they might be seeing you, let's say 3 or 6 months after surgery, seeing you more often than seeing me. And if you can identify that the rate of the weight loss is not consistent with 1 to 2 pounds a week, that's also another way that you can intervene and help the patient. That's end. If I can take any questions if